So everybody, thank you for sharing with us this webinar. This is the first international webinar for Azhar University. Susan, my university called Azhar University in Cairo. It is the Egypt's oldest degree granting university and is renowned as Islam's most prestigious university in the world. I think it's established more than 1,000 years ago. Today we have Professor Susan Mackinnon. Dr. Mackinnon graduated from medical school at Queen's University in Kingston, Ontario, Canada, and she trained in general surgery and the plastic surgery in the University of Toronto. Dr. Mackinnon joined the surgical staff at University of Toronto in 1982, and in 1988 she was awarded the Medal Prize in Surgery from Royal College of Physicians and Surgeons for her work in nerve regeneration. 1991, Dr. Mackinnon joined the Department of Surgery at Washington University School of Medicine. Her research work in St. Louis has been funded and has investigated first nerve allotransplantation and nerve regeneration, which by this work has resulted in a new strategies of nerve transfer to reconstruct nerve injuries. She has been chief of plastic surgery since 1996. Dr. Mackinnon published a classic textbook, Surgery for Peripheral Nerve, more than 500 peer-reviewed publications, 200, I think, book chapters, and new comprehensive text nerve surgery. And her open access website provided surgical videos with all the secret ingredients and are used globally to improve the care of nerve injured patients. Dr. Mackinnon is a past president of American Society of Peripheral Nerve, American Association of Hand Surgery, American Association of Plastic Surgery, and the Plastic Surgery Research Council. So, and I think, Dr. Mackinnon, you are known everywhere by the nerve lady. And thank you for sharing with us. Thank you very much.
Thank you for that very kind invitation. It's exciting for Andrew and I to join you today and share our passion for improving outcomes for patients with nerve injuries. It's an important specialty, and it's such a new specialty. We were talking just before we started this about the title, There's No Crying in Innovation. There's lots of crying in innovation. I'm going to share with you today some of my tears, but also the concept of innovation and how it happens and what happens when it happens. And just like all of us are interested in being experts looking after patients with nerve injuries, there are people that study what happens when a new idea is presented. I wish I'd known some of those things. I just wanted to mention that this is such a new specialty. This is a drawing from that first textbook, and Terry Watkinson did these drawings, and this is the median nerve in the forearm, and I hope you can see there's just no topography there. It's just a scramble of fascicles. Good luck. This is the front picture of our textbook now, which you're seeing on the screen, and there's specific topography there. This is the pronator group, and especially in this holy time of Ramadan, it's interesting to see that our maker has helped us by taking the paintbrush and drawing small microvessels on either side of that pronator, those little microvessels. Can you see the pointer, Andrew, there?
No.
No?
No.
Okay, well there's small vessels on top of that pronator fascicle. And then you can see the green fascicles are sensory. And over on the very bottom is the anterior interosseous nerve group. And here, the flexors of the wrist and fingers. So does this pointer work, Andrew, or not? When I'm pointing, it's not showing anything? No?
No, I don't see the pointer.
Okay, then I won't point. All right, good. So this is such a new specialty. Here we are in this very short period of time, understanding that there's specific topography inside the nerve. Can you imagine doing a surgery and not understanding a key point of the anatomy? That's ridiculous. So just to see even that example of how new this specialty is, tells us that when we study innovation, we're in for an interesting trip. So I'm going to just minute that. So here's a little story about moving from nerve repair to nerve graft to nerve transfer. I started my clinical practice at the University of Toronto after training in hand and nerve and plastic surgery, microsurgery, in 1982. Okay, I'll advance from the bottom then. In 1982, and here's a picture of me in 1982 with Sir Sidney Sunderland, and in 1984 with Hanno Malesi, the amazing plastic surgeon from Vienna. And I did not know at that time that these two gentlemen were on the opposite sides of the paradigm shift story from nerve repair to nerve grafting. I asked Hanno Malesi about what was his experience moving from nerve repair to nerve grafting. And I wouldn't say moving from nerve repair to nerve grafting, but using nerve grafts when a nerve repair was not indicated, when there'd be too much tension. And he emailed me. This is in preparation for the first Prezi talk that Andrew and I gave. And I emailed him to tell me his story. I was giving my talk about the challenges of trying to innovate nerve transfers to be included with nerve repair and nerve grafts. Maybe you could make sure you turn your audio off. So if I could just read this email to you. I read it to myself earlier this morning. And if you could turn the audio, your audio's off, that would be easier on my ears. Okay. All right. So here's his email to me when I asked him about a visit of the, I'm going to wait until you get it settled. It's racket in my ear. It's good? Okay. About a visit that he mentioned happened in 1970, and it was Eric Moberg who came. And then Hanno said in 1963, he was in the United States, he met James Smith. And James Smith had learned about the microscope from Jacobson. And when he returned to Vienna, Hanno started to do experiments with sutures using the microscope. And he got good recovery, but only if tension was avoided. The only way to achieve a good result was to use a nerve graft. And I started to do clinical cases after having changed the technique, and I got surprisingly good results. You'll see later in the talk, there's a comment from our associates in Egypt where they were saying they got surprisingly good results with an end-to-side nerve transfer. His first presentation, however, were received with hesitation and criticism. In 1970, he had a discussion with Eric Moberg. And after that, Eric Moberg asked to come to Vienna to see his work. And he brought with him Donald Brooks, who had worked with Sir Herbert Seddon. Donald Brooks knew about the cable grafts, but the work with Seddon had had only bad results. Consequently, Donald Brooks was especially critical. After the visit, Moberg and Brooks were convinced of the advantage of nerve grafts, and they started to support his work, in contrast to others who continued with aversion. This culminated in 1971 when he gave his first talk at the annual meeting. This is his first invitation to America in San Francisco, and he gave his first talk, and he was warned before he would be attacked. Harry Bunke, another innovator in plastic surgery, was his discusser, and he protected him. So you can see even in here, there are the words and the adjectives of a great debate, if not an attack, and needing protection and hesitism and criticism. So I asked him quickly after that for more information. And he said, in the late 60s and early 70s, there was a bias against nerve grafting. Sterling Bennell and Boys had cases where they used cable grafts like Seddon with tension, poor results. Marmar at that time was doing allografts, and imagine expecting a good result with allografts. The main criticizer was Leonard Goldner, who was the professor of orthopedics at Duke. And then he says this: the breakthrough was 1978 at a symposium in Duke, led by Leonard Goldner in North Carolina. And Dr. Goldner presented a case of a boy having suffered a radial nerve defect of 10 centimeters, and he resected that 10 centimeters of humerus in order to bring the two ends of the radial nerve together end to end with a nerve repair. He got a mediocre result, and at the same meeting, Raymond Curtis, I was Raymond Curtis's last fellow in Baltimore in 1981-82. Raymond Curtis reported 25 cases of long defects of the radial nerve managed by grafts with Malaysi's technique with much superior results. I think those two emails really tell the story of anyone in surgery who is trying to improve, move out of an existing paradigm. And that story of Hannah Malaysi's is almost identical to my story of my experience working with nerve grafts, expanding them, studying them, trying to get nerve allografts to be the next best nerve graft. I had no intention of innovating into nerve transfers. I was just trying to get a better result for patients. I was trained in nerve grafting, and my logical conclusion in the early 80s with the introduction of immunosuppression, cyclosporin, was to do nerve allografts. And I spent more than 10 years working in the laboratory on that and did a couple of dozen of nerve allografts with results that were no better than nerve graft. And that's when we started to move into nerve transfers. So those are personal experiences of two nerve surgeons, but people have studied this whole process. There are two books that were written in 1962, Thomas Kuhn and Everett Rogers. Thomas Kuhn's book, The Structure of Scientific Revolutions, is a book that all surgeons might consider reading. He describes the paradigm shift when there is a sudden break in a tradition-bound method. He says that this will take the scientific discipline and throw it into a state of crisis. Frequently, there'll be an intellectual battle between the new paradigm supporters and the old paradigm holdouts. And then he quotes in his book from Max Planck, "A new scientific truth does not triumph by convincing its opponents, but rather because its opponents eventually die and a new generation grows up, which is familiar with the new paradigm." That's pretty harsh, isn't it? He has had described a Kuhn cycle of innovation, and it is associated with these 3 C's when you're changing from one paradigm based on usually 2 to 3 decades of science into a new paradigm. It's introduced almost as though it came out of nowhere, even though there's been decades of hard work to bring it to fruition. But it's received with the 3 C's: controversy, uncertainty, and criticism. So as you're doing some new innovation and you start to experience this, you can remember that that's the normal. And in Thomas Kuhn's book, he gives example from the beginning of the scientific method and medicine of issues with paradigm shifts. The second book from 1962 is an incredible book. It's Diffusion of Innovations. I have it here beside me. It's very thick. It's daunting to look at. It's written by Everett Rogers, based on his work as someone who studied communication. He did his degrees at the University of Iowa, which is a state just north of where Andrew and I are right now in Missouri, in the heartland of the United States of America, in the Farm Belt. And he studied innovation, and he used a model of a number of farmers in this state of Iowa, in the middle of the United States, as they were introduced to the new possibility of a new pesticide, a new herbicide, and a new way to improve their crop output. And he studied these farmers over several years, from 1948 until 1956. And this is what he found in his studies, that this new innovation came from a scientist to farmer number one in 1948. And farmer number one was also a scientist in his own right and checked out the utility of this new weed, pesticide, herbicide, this new product to enhance the output of their corn crops. And he decided that that scientist was right and that this was a useful product. So he would be the new innovator in 1948. He had to wait 2 years for his first adopter. There's the first adopter. 2 years to wait for the first adopter. Once he had identified that first adopter, however, all the work then was done by that first adopter. This farmer was very respected and known within the community of the other farmers. And after getting that information from the first innovator, that first adopter distributed that information to almost all the other farmers. But this is how it distributed. One farmer in 1951, 3 in 52, 3 in 53, 2 in 54, 1 in 55, and finally the last 2 laggards in 1956. This is the S curve of adoption of a new idea by diffusion, person to person to person, in a social construct of people. You'll see this S curve several times through this talk today. The other thing that Everett Rogers did was he studied the personalities of the different people within the social systems. And he noted that innovators tend to be scientists, but they're free from constraints. They're outside the in crowd. But that allows them to be free to think. They're not having to buy into what we would call group think. They're out there working on their science, asking their questions, doing their research, and then they come up with an idea. Then they meet the early adopters. The early adopters, like that first farmer in 1950. Early adopters also favor scientific thinking. They're thoughtful, but they are connected to the social system. For us, it would be the other surgeons within the scientific surgical community. And those early adopters then connect that information to the early majority. When you reach enough early adopters of about 15%, then it rapidly gets distributed to the early majority. And those people, those individuals, follow the leaders or follow the early adopters. And then finally, those individuals that are very risk averse, conservative thinking, they would be the late majority, and eventually the new paradigm would find its way into the whole symptom. So here is the S curve. You can see the yellow S curve of Everett Rogers' diffusion of innovation. And you can see then he broke down the percentages of types. So a small number are the innovators, 2%. 13 to 15 to 20% will be the early adopters. And once you get the early adopters adopting a new idea, you can't stop it. That would be the tipping point. By contrast, if you don't reach that 15%, then this would be an idea before its time. Nerve transfers were described and published in the classic old surgical textbooks in 1911. All the drawings of the strange nerve transfers that we do, end to end, reverse end to side, supercharge, cross graphs, kissing graphs, all of those little nerve transfers have been described before, but they didn't tip. Those ideas didn't move forward. So this would be Scott's parabola. And it's the same, it's the same as the S curve, but the S curve is over time, 1948 to 1955, and Scott's parabola is just the distribution of the different members of that social group. Malcolm Gladwell published a book called The Tipping Point. And what he did was acceptate Everett Rogers' work, and he described mavens, connectors, and salespeople. And he described needing all of those people. So you as a researcher and a scientist working in the lab, trying to come up with an idea to make nerves be better, that innovator, that maven, that researcher, that would be me, for example, I cannot make my ideas tip. I need to have people like you that are interested in this, that are thoughtful, that are scientists, that are interested in the same problem, and can take an idea I might have and test it yourself. The other thing in this large textbook that Everett Rogers discusses is the fact that those early adopters, they'll change your technique. They'll change your technique. How dare they change their technique? Instead of putting the supercharge at 9 centimeters proximal to the wrist crease, they might put it at 7 centimeters proximal to the wrist crease. They might not use this particular transfer. They might do that transfer. So the innovators have to be prepared and expect that there will be modifications of the innovation, and we have to be looking for people like you who are the first adopters. Nerve transfers have not tipped yet. We've identified early adopters. You are all here, you're obviously early adopters, but as far as really getting it into mainstream, we're still in the early stages of nerve transfers. So the tipping point will be when you have 20% of surgeons using nerve transfers, and then you can't stop it. Until then, it's still a little bit fragile. Now here is a TED Talk by Derek Sivers, which is fabulous. I just love it. I've watched it many times. And he is talking about exactly what Everett Rogers was talking about.
So ladies and gentlemen, at TED, we talk a lot about leadership and how to make a movement. So let's watch a movement happen, start to finish, in under 3 minutes and dissect some lessons from it. First, of course, you know, a leader needs the guts to stand out and be ridiculed. But what he's doing is so easy to follow. So here's his first follower with a crucial role. He's going to show everyone else how to follow. Now notice that the leader embraces him as an equal. So now it's not about the leader anymore, it's about them, plural. Now there he is calling to his friends. Now if you notice that the first follower is actually an underestimated form of leadership in itself. It takes guts to stand out like that. The first follower is what transforms a lone nut into a leader. And here comes a second follower. Now it's not a lone nut, it's not 2 nuts, 3 is a crowd, and the crowd is news. So a movement must be public. It's important to show not just the leader, but the followers, because you find that new followers emulate the followers, not the leader. Now here come 2 more people, and immediately after, 3 more people. Now we've got momentum. This is the tipping point. Now we've got a movement. So notice that as more people join in, it's less risky. So those that were sitting on the fence before now have no reason not to. They won't stand out, they won't be ridiculed, but they will be part of the in crowd if they hurry. So over the next minute, you'll see all of the those that prefer to stick with the crowd, because eventually they would be ridiculed for not joining in. And that's how you make a movement. But let's recap some lessons from this. So first, if you are the type, like the shirtless dancing guy, that is standing alone, remember the importance of nurturing your first few followers as equals. So it's clearly about the movement, not you. Okay, but we might have missed the real lesson here. The biggest lesson, if you noticed, did you catch it? Is that leadership is over-glorified. That yes, it was the shirtless guy was first, and he'll get all the credit, but it was really the first follower that transformed the lone nut into a leader. So as we're told that we should all be leaders, that would be really ineffective. If you really care about starting a movement, have the courage to follow and show others how to follow. And when you find a lone nut doing something great, have the guts to be the first one to stand up and join in. And what a perfect place to do that, TED. Thanks.
Not all innovations tip. I've mentioned that before, that in 1911, there were all of these drawings about nerve transfers and it didn't tip. Similarly, if you look at the keyboard, 1873, the QWERTY keyboard was introduced, and in 1932, the Dvorak. On the home row, on the QWERTY, only 32% of the most used keys are represented. More efficiently, on the home row of the Dvorak, 70% are. So here is a much more efficient way of keying, a faster way of keying, but we have not dropped, even now the computer I'm looking at, it's the QWERTY. So why was that? It did not tip, even though it was a better keyboard. The reason was that when the keyboards were the typewriters rather, were first introduced in the 1800s, they didn't want people to type quickly. They wanted them to type slowly, or the keys would jam. And they put on that top key the words that would spell typewriter. So if you take that QWERTY, that's why it's called QWERTY, you can rearrange those letters on that top key, and the salespeople could rapidly type out typewriter, making the purchaser think they had a rapid instrument here, but actually it was designed to be slow. And this much better layout was never adopted. Similarly, 1911 with the earlier descriptions of nerve transfers, and here we are, 2020, and it still hasn't tipped. Similar to the idea of preventing scurvy by vitamin C. Vasco da Gama took his amazing voyage with 3 boats. Only one of them had citrus on it, and everyone in the other 2 boats died. There was a PhD study on scurvy in 1753, but it wasn't until 1796, 3 centuries later, that it became the norm to issue lime juice in the British Royal Navy. The same with our, well, not 3 centuries, but in general, scientific medical information diffuses over 17 years, and that's only 14% of knowledge diffusing over 17 years. In fact, as we move from the basic research to the clinic to general practice, that information, for example, in the United States, just the recommendations for colonoscopies to prevent colon cancer is only used by 50% of people that are eligible to have that screening. So this is a very slow experience. My first nerve transfers were in the late 1980s with the anterior interosseous nerve end to end to the deep motor branch of the ulnar nerve, and in 1991 with the medial pectoral nerve to the musculocutaneous nerve. And here it is so many decades later, and we're still talking about this quote unquote new novel idea of nerve transfers. So here we have the definition of diffusion. It's the passive spread of new practices. And what I'm going to talk about now in the latter part of this talk is the new idea of dissemination and implementation science. Dissemination, by definition, is the active spread of these new ideas. Implementation is the science to evaluate the efficacy and adoption of that new idea into actual day-to-day practice. But looking at diffusion, we've talked about Rogers' parabola, and here's Scott's parabola. Rogers' parabola is this big textbook. I have it here. It's got over 500 pages in it. Scott's parabola was just a single page or 2 in BMJ in 2001, where he talked about the birth and death of a surgical procedure. And if you notice on the left-hand side of your screen, that left-hand side of Scott's parabola is really the S-curve of Rogers' parabola. Taking the surgery out, a surgery now that could be replaced by something better, is what Scott added. And he talked about the slow, passive issue of people doubting it, controversy, discussion with other papers, authorities saying don't do it, maybe a medical legal case, and then it falls into disuse. And eventually the nurses in the operating room wonder, what are we having all these expensive, obsolete equipment here for procedures that we never do? So to try to maybe improve the safety of innovation. This is a new interest all around the world. And in Annals of Surgery, our lead surgical journal last year, these authors were talking about the ideal framework for surgical innovation. And the ideal came from the words idea, development, exploration, assessment, long-term monitoring. So they had a nice acronym for this. But really, it's just what we do now. This is how we present new ideas. When I did median to radial nerve transfer, I presented my first case after I got a result as a case report. I presented in plastic surgery. The second case went into a journal of neurosurgery. The third case went into a hand surgery journal. So with a new idea, I put one case, my first, second, and third cases, into the parent journals of our specialty as nerve surgeons to see what others would think. And then a case series, and then an RCT, and then finally a registry. But these ideas still are passive. So what about active? How can we more efficiently cut down that 17 years where in that time we only get 14% of potentially excellent ideas out into practice? Well, in the United States, the National Institute of Health is our funding agency. And just very recently, they have discussed and are funding what we would describe as a practical way to get information out quickly and evaluated quickly and accurately. They talk about the blue highways. We have maps now, we just have GPS or TomTom, but there were maps, and in the maps, if I wanted to go from here to New York City, I would go the fastest route and it would be a red highway. But the back roads into the small towns, villages, small cities, where the majority of people in our country live, are located on blue highways. So it's the idea of studying the practicality of getting an idea into practice where it can treat most patients most efficiently. And so this is this area we have funding, and have had funding for quite a while for well, of course, basic science research, and then that's where the majority of the funding goes, but also now into bedside research, clinical, human clinical research, and then having that into clinical practice. All over the world, we're trying to do that aggressively and quickly now as we go from the bench to the research to the clinical practice to help treat this horrible COVID pandemic that we're all suffering from. So what has been introduced now is T3, and that is dissemination, research, and implementation research and science. And these are now funded areas of potential investigation. And I'm going to use this concept now to discuss what Andrew and I have tried to do over the last 11 years that we've had our surgical videos available for free globally, and where we would, if we were to find funding, which we don't have now, but if we could get funding, to be able to not only disseminate it, but study the dissemination, and more importantly, find out how useful it was in flattening surgical innovations around the world so it could translate safely and efficiently to look after patients with nerve injuries. There are some master's programs and PhD programs now to just become a scientist of D&I, dissemination and implementation, but only 3 master's programs in the United States and Canada. They come under different names: knowledge translation at the University of Toronto, research implementation, research translation. And there is a journal, it's a new journal, but it has a really good impact factor for a new journal, and open access, so this is available around the world. Well, what about the implementation side of that? So this is the other part of the D&I research, dissemination and implementation research. And as we're wanting to put grants in to get funding, we need to understand the language of this new science. We know the language of basic research, but we need to know the language of the new science. And the creators of this new idea have set those parameters. So they will talk about outer setting, inner setting, and individuals. That's the general surgical environment, the particular hospital or country, and the particular individual surgeons, and then what has to be accounted and discussed if you're expecting to be funded for this new work. So the outer setting, what country is this occurring in? What are the surgical regulations, the privacy regulations in that country or city or hospital? And then in the inner setting, what resources are available in the hospital? Do you have microscopes? Do you have physical therapists who are trained to do motor re-education? And then, just as Everett Rogers discussed the characteristics of those individuals that were the innovators versus the laggards, the early adopters versus the late majority, the characteristics of the particular individuals that would be needed in order to have something advance. So all of you, by definition, being here today, this evening, in the middle of a pandemic, have defined yourselves as early adopters with the characteristics that Everett Rogers studied. So the other issues are, you need to, when you're doing this, you need to think about how acceptable the innovation is, whether or not the innovation will be adopted. Is it feasible to do this? Do they have the tools necessary to do it? And the fidelity, how close they are to the individual, the first innovation. But I know that, and Rogers mentions this, I know that in surgery, the expectation is that people will take your innovation and they'll want to make it their own. In order to pitch it, in order to connect to other surgeons, it's their patients, and they need to try the innovation out, take what they like, discard what they don't, and use this new innovation as a stepping stone to perhaps even something slightly better. And then sustainability, long-term, is their fidelity to this new operation. So without knowing anything about D&I research, Andrew and I really have been doing the dissemination component for over a decade now. We actually started working on this at the time of the Afghanistan into Iraq war. My husband, who's a thoracic surgeon, said, Susan, you need to go there now. You need to go to the Middle East and do nerve surgery. And I said, Alec, I have 4 children. I have 11 grandchildren. I don't want to go there. I'm too afraid. And that's when Andrew and I came up with an idea of taking some of the operations that we had innovated and making them available, because I was too afraid to go into the conflict zone, to make it available if there were people that would want that. And now we've had over 4 million views, 165 countries. And they're color-coded here for watch time, but you can see that Egypt and Great Britain and Turkey and India, Australia, Brazil, countries are the Netherlands and Belgium. The countries are using it even more than the United States, and more than Alaska, and more than Greenland. But 68% of our videos have been viewed outside of the United States. That is dissemination. And our whole plan was to be able to take surgical innovations and get them into the hands of surgeons in practice. We all know how hard it is to train to be a surgeon. It's a very slow process. It's emotionally, physically, financially expensive. And it is done with a teacher with us all the time. We have the experience of having master teachers that we respect and learn from. And then when we become attending surgeons, that tight relationship is gone. In fact, in the United States, it can become your competitor. So someone that was training you and helping you now all of a sudden is competing with you, or vice versa. So our idea was we would take a master surgeon who had developed a new technique, a new innovation, and was good at teaching. And also, and most importantly, wanted to give, like the introduction that Amir said, wanted to give the recipes away, wanted to give the tricks away, all the ingredients. And you know how hard it is when you go to your grandmother and say, I want to know how to make that recipe, because when you're not here, I do not want to lose the taste of that. It's very challenging. Even though your grandmother would like you always to be making her specific meal, it's hard when it's just so intuitive to them. They've forgotten actually how they even learned it. It's just a dash of this and a little of this. And so the master surgeon has to be able to want to give it away and know how to give it away. And that's what we've tried to do with our program. We've recently, it's in press, it's actually not published yet, but this year will be published in, again, Annals of Surgery, that very important American surgical journal, our experience over 11 years with all of these videos. And as you know, Andrew has made short videos and long videos. The short videos are just staccato, step, 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 step. The long videos are the cadence and the flow of this surgical procedure. Sometimes it's slow and frustrating. Other times it's easy and faster. But there's definitely a flow, almost like a concert when you're running an operation. And it was assumed that all these videos, surgical videos, should be the same length, that surgeons can only have a 10-minute attention span, which we know as surgeons is not true. We'll have surgeries that are short, and they could even be intense and short, or long. So just as there's variations to the surgeries, there needs to be variations to the videos. And we were able to show that with the analytics of all of these 141 videos that Andrew's made. We were also able to look at where the viewer was not watching or paying attention. And there is a cadence, this up and down of the long video below, the short video above, and then that flow up and down is where we're seeing engagement, disengagement of the surgeons. And sometimes it's appropriate because it's a slower part of the surgery. You still need to do it, but at other times, we've not used the video to the maximum. And you can see here that there's a dip in engagement when we're resecting the intramuscular septums on this ulnar nerve transposition. And so Andrew and I went back and did another video, and where there's that dip, we said, you weren't paying attention here before. If you don't pay attention, especially distally, you'll get a kink on your ulnar nerve distally. You won't have a nice straight line flow of that ulnar nerve. It'll kink down, kink distally, and you'll get a poor result. So we were able to monitor audience retention and correct where we had not taught it as well as we wanted to. So now we move into what we would like to do, and really have just done this in a very early stage. And in the center, you see the surgical video. So that's where we are now. We have these videos, but continue to do this work, so it's available for free, is to add clinical judgment. So this is what goes on in the clinic. It's how do I pick the patients? It's who do I select for what surgery? Who do I select not to operate on? And then finally, we want to add the post-operative therapy, which is very key, especially in the motor nerve transfers. So evaluate and coach so that if there's questions about a procedure, we're able to, in real time, potentially, or at least with written feedback, be able to help discuss this. So we would be doing coaching, video coaching, so we could look at surgical video to comment on repairs, or we could look at just photographs so that we could have feedback in a written feedback type of way. So here on the left, you see a photograph that a surgeon has sent me. It's not high quality photograph, but I can see from that the posterior and anterior crural intramuscular septums on the perineal nerve have not been released. What were they thinking? They've opened the fascia. They've identified beautifully the common perineal nerve below the fibular head, but those septums haven't been released. And then I can say, you absolutely need to release those septums, and here's how you do it. They can look then at the video, notice what they've missed, and then a follow-up video, that perineal nerve is nicely released and the septums are gone. So there's no point in having these videos out if they are done on the wrong patient at the wrong time. And that is what we actually want to do. And I want to now close with one example of one operation and how we would like to proceed with all of the operations. So here we have again Rogers parabola, Rogers S-curve. And now we add the right-hand side of Scott's parabola to the S-curve of Rogers' diffusion theory. And we have both the Rogers parabola and Scott's parabola. And then you can see over on the far left, an idea. Let's pick nerve transfer and know that the idea before its time was in 1911-ish. And then let's take within the nerve transfers, just the supercharged end-to-side nerve transfer of the anterior interosseous nerve to the motor branch of the ulnar nerve. So these are publication dates, and we all know that, for example, 1994 was Viterbo's publication of his nerve transfer. In 1991, he came to the American Society for Peripheral Nerve with a binder showing his research. It had not been published. So all of these dates of publications would come on after a few years of work before the article would be published. I'd also like to draw your attention, the cartoon that Andrew's drawn of the anterior interosseous nerve in green going to the motor component of the ulnar nerve in red. So the ulnar nerve is denervated, that's why it's red, like stop, this is not good. And the AIN transfer is green, this is good. And we're supercharging, we're asking that anterior interosseous nerve to go inside of that denervated nerve. By contrast, if you look on the very lower left, there's the drawing of Viterbo's idea of taking a denervated nerve to the side of an innervated nerve and asking the innervated nerve to sprout into the denervated nerve, not the innervated nerve to sprout into the denervated nerve. So that's the difference in the supercharge, which initially I called it the reverse endoside, but it was too cumbersome because then I had to talk about the traditional endoside. So Viterbo's traditional endoside is denervated to the side of normal, sucking out nerves into the denervated, and the supercharge is pushing normal nerves into the denervated. I have to plug my computer in. I will be right back. When I was setting up to be close as I could to my best connection. I forgot to plug in. So I hope it's okay. Is that okay, Andrew? Yeah, it's good. So here we go. So this is the story, and where I am now with the supercharge is actually not a tipping point. Where I am with the supercharge is the beginning of the early adopters. And some of those early adopters are definitely in the audience today, and I'm so honored to have you here and grateful. So Viterbo came to the meeting in 1991, and he talked to us about the endoside. And I can tell you, everyone was critical and skeptical, including me. But everyone with a nerve lab went back to their lab after that meeting in 1991 and tested his idea. And so did our lab. We did studies on nerve transfers all through the next decade or so, and looked at sensory regeneration, motor regeneration, crush injuries, graft, everything. And at the end of that experience, we realized that, oh, he was pretty right in the first place. So, and 2005, 2008, 2005, John Isaacs presented a rat study on the reverse endoside. And he had done the complete opposite of Viterbo. He was asking a normal nerve to jump inside of a denervated nerve. I was highly critical of that. I thought, that's ridiculous. He didn't have the transgenic rats that we had developed. So in our laboratory, we evaluated his results. And this was over several years. And what we found using our transgenics was that you could take the normal perineal nerve and sew it to the side of the denervated tibial nerve. And the green is the axons that you can see under fluorescent microscope. So you can see that tibial nerve in the far left panel has got no nerves in it. And then at 3 days, 7 days, 10 days, 35 days, that denervated tibial nerve fills up with nerves. That's crazy, but it's true. We repeated that study because I didn't believe it when I saw it. But you can see below that we were getting as many nerves into that tibial nerve as if we went end to end as to end to side. So when we completed the 2 studies, then I did my first supercharge AIN to ulnar motor in 2009. And the patient he had very severe cubital tunnel, an operation that made him worse. He had no intrinsic function. And I redid his ulnar nerve at the elbow and supercharged him, and he got back his intrinsic muscles. That was astonishing to me. My next patient, a year later, after I got this result, was an 11-year-old girl, same operation, same result. And I published both of those articles and started talking about it at a meeting. At a meeting, I presented our early results, and the Journal of Hand Surgery requested that I write a technique article and that Andrew provide a video. So that's highly unusual to have a journal ask you for something like that, especially at the beginning of this whole experience. And so we did. And then there was a comment afterwards that was titled, basically, you shouldn't be doing this operation. It was titled, Supercharge End-to-Side Nerve Transfer Too Soon for Prime Time? Question mark. We then did a series where we were writing up our results, and you've all seen these pictures of that supercharge. And these are the comments from that article. First of all, asking why we were even invited, why we even did a technical guide to something that was so new and controversial. And we responded. These two little letters to the editor are interesting to read, and they are the same experience that Hannah Malacy had. So now when this operation was so new and new for me as well, I was very into the idea of getting some case series out. So Kristen Dobbage, who is a nerve surgeon at University of Toronto at Sick Kids, was my fellow. And she evaluated my first 55 patients, published that result, and put that into plastic and reconstructive surgery. And then in 2016, a publication from my first adopter, Steve Moran, Chief of Plastic Surgery at Mayo. And I am so grateful. So just like that Derek Sivers crazy TED Talk, there I am dancing by myself, all on my own, doing this sets transfer, no first adopter. And then there is my first adopter, Steve Moran. Thank you, Steve Moran. Where he looked at, it was just a small number of patients, but he supported the idea. He evaluated the idea himself. And he had sets transfer, no sets transfer, and he had intrinsic recovery better with the sets transfer. I slept better that night with that paper published. And then here from Egypt, where another early adopter, well, this is the second early adopter, so it hasn't reached the tipping point. We need 20% of the whole group, 14 to 15 to 20% of the whole group before we have a tipping point. So my second adopter here, this was with transection injuries at the various levels in the arm. And here you can see the recovery of intrinsic function to an M3 level if it's transected high or at the elbow, or when at, you know, zone 2 where it would be a more favorable, even at the very far levels up in the arm, 84% recovered MRC3+. And I like the last sentence. The last sentence is, surprisingly, 84% of patients included in the proximal injuries recovered to the same extent as more distally. That is odd. How is that possible? But based on this article and this article, again from different institutions in Egypt, here you see, this is transection again, and you can see better results in the ulnar nerve repair plus the sets than the ulnar nerve repair alone. So based on this, I don't know why I would ever do an end-to-end AIN to ulnar motor again. I think I would always do a supercharge. But interestingly, the last sentence of this article, and was chosen by Journal of Hand Surgery as an editor's choice. That is a high honor to have the editor of the journal choose your paper. But the last sentence is, as we always do with ed papers, we always say the limitations of our study include blah, blah, blah. But the last sentence is, these shortcomings suggest that the results of this study should be considered with caution. That would take me back to the letters to the editor suggesting that the sets transfer was an operation before its time. So we definitely have not reached the tipping point on this. So how could I help it? I was becoming a little nervous, and I had seen a couple of results where I didn't get intrinsics back, and I was concerned. I loved the operation. I got great results, but I saw one or two where I didn't get a good result, and I was worried. And I was worried someone who was not my early adopter would publish bad results. And I wanted to publish my results, good and bad, as quickly as I could so I could get ahead of that. So I realized that in my head somewhere was the recipe for when I would do a sets and when I wouldn't. And I needed to get that out. And I took paper and pencil, and I couldn't do with paper and pencil. There were too many moving targets. So in the operating room, and I'll show you this in a minute, I played out with what the algorithm was. I also, Jana Dangler, who is doing her master's in DNI research at University of Toronto, and actually Kristen Davidge, who did the first set of 50-some patients, had a master's in DNI research from University of Toronto. But Jana Dangler then looked up my next 42 patients. And I said, Jana, we've got to go through everything on these patients, look at the electrical studies. We've got to identify the failures. We've got to figure out why they didn't work, and we've got to publish it. And what we found was, of these 42 patients, only 3 didn't work. And those 3 patients, I basically broke my own rules for who to operate on. So this is a picture that my associate, John Felder, took. And some of you met him, I think, when Andrew and John went to Egypt a few years ago. He took this picture of me. This is a table, it's a room just outside the ORs where we dictate and wait for turnover so we can start the next case. So I took these stickies, and the electrodiagnostic studies are on the blue stickies. Patient presentations are on the large pale yellow. So whether they have intrinsic weakness in the ring and small finger, whether they have intrinsic weakness, whether they have extra numbness in the ring and small finger. And then the operations are ulnar nerve alone, transposition alone, light blue square, ulnar nerve plus guions. I'll do an ulnar nerve and guions. Profundus tenodesis, purple, the cross nerve allograft from median to ulnar to get sensation in the ulnar nerve, also in purple. And then up at the very top, that's when I do the sets. And that is the trip. I wish I had my pointer here to take you, but you can see that I start with failed conservative management of patients with cubital tunnel, and then say, how do I go to just doing an ulnar nerve transposition? What do I see on the electrical studies in the royal blue? What do I see on clinical examination that would take me to do a cross sensory graphs or profundus tenodesis? And then at the very top where their orange pen is, that's where I do a sets. Otherwise, I don't. And I don't because either they don't need it, or it won't work. And from that, we published an algorithm, and then we looked at the last 44 patients over 5 years and identified where they failed. And those 3 failures failed because I broke my rules. They didn't have fibrillations. The intrinsic muscles were basically chronically denervated. There were no open end plates, or my pronator quadratus was not normal. But that's when they didn't work. So that's that story, and that is to try to move that Rogers S-curve over to the left, or shift Scott's parabola over to the left. And to do that more aggressively, we identified the clinical judgment component. I talked about that when I said we want to add something on the before the surgeries. We want to teach people how I think and how I pick and choose patients. I get good results, and pretty much because of my patient selection. I know when it won't work, and I know when it will work. It's not that it always works, but I don't do an operation and I know it won't work. I won't do a 16 centimeter nerve graft on a perineal nerve injury. It won't work. Might be a nice operation to do, but it won't work. So on this same procedure, the SETS procedure, this is what Andrew and I proceeded to do. And some of you may have actually done this study with us. We had, we offered it to 279 nerve surgeons, and we gave them questions before, then we taught them my thought process, and then we questioned them afterwards, and then we questioned them in a delayed fashion to look at retention. And we used a short lecture and we used a long lecture. And actually they liked the long lecture better than the short lecture. But they used both, but they liked the long lecture better. And you can see on the right side that we asked them questions, and then we got their answers, and then we educated them, and they improved dramatically on their correct answers. There was one area where it was not 90% retention, and that was in an area that included conduction block, and that's because I didn't teach it right. So Andrew and I now are working on fixing that and adding to this educational module how to understand the difference between conduction block and decrease in conduction velocity. But of the 41 surgeons who had not done the SETS, 78 said they would consider doing that. In our institution, we have Virginia McPhail, who is an outcomes researcher, and she has written a single article on de-implementation science. So how to take an operation where now there's a better operation and get rid of the old operation and bring in the new operation. For me, and that of course would make that whole Scott's parabola really tight, time-wise, not that decade after decade. Look at how many decades from 1991, when I first met Vitterabo, to here we are with the supercharge in 2020, decades later, and we haven't yet tipped on that supercharge. But as far as I'm concerned in my practice, the end-to-end AIN to ulnar, which I did in the mid to late 80s, I wouldn't do that now. Not with the results of the work from my Egyptian colleagues, who have shown excellent intrinsic function, even with proximal injuries. Would rather leave it an option for some recovery. I would probably just always do the enticide. So I would say that with this surgery, this one operation, I have taken the Rogers innovation and dissemination and got rid of one operation by introducing the second operation. And then of course, I'm grateful for the visitors that have come to visit. This was before. Who knows if this will ever happen again, that we will be standing so closely together. But at least we can be together by Zoom, and I am grateful for that. I would not be having this conversation with you all except for that hideous virus. And I'm grateful for this conversation. And I'll remind you, I started with Thomas Kuhn and end with Thomas Kuhn. And he says, though a generation is sometimes required to effect the change, scientific communities have again and again been converted to new paradigms. So thank you all so much for your attention today. And thank you for helping patients with nerve injuries to have better outlook and better outcomes.
That was great, Susan. Amir, do you have any questions?
Mute me.
Shall I?
There we go. I got you.
Yeah, okay, good.
Thanks, Susan. It's a great lecture. Very great. And you lighten some Egyptian papers. I saw some of them, but yeah, thanks for that. So any questions from the floor, please put in chat, please. So it's thank you. I just would like, though, we have people from more than 15 countries. We have from Morocco, Yemen, Pakistan, Egypt, Kuwait, Argentina,
Wow.
India, Australia, Algeria, Leeds, UK, Mexico, Serbia,
Gosh, well, I'm,
Nigeria,
yeah,
Colombia, St. Louis. This is Andrew from St. Louis, Iran.
wow,
So
it's amazing. Yeah, I'm
30 countries. We have.
humbled.
It's all thank you. So any question to Dr. Mackinnon, and from Saudi Arabia, of course. There is question from Dr. Mekki. He is my colleague. What's the time limit for anterior interosseous to ulnar nerve?
So the time limit, can you hear me okay, Amir?
Yeah, I can.
Yeah, so the time limit is the same as any time limit. And you can tell if you're still okay as long as you have evidence on your electrodiagnostic studies of insertional activity, like fibrillations or positive sharp waves. That means there are motor unit end plates that want a nerve. So if you have that, then you should do the transfer. If we go in and we are, at about a year, right? The cutoff in general is about a year if you have complete denervation. And you'll say, well, I'll go in, I'll take a look. If the muscle looks like fat, you're not going to do any transfer or repair. If you even touch the muscle or stimulate the muscle and you get a response, then you know that there's still some insertional activity. But if you tap the muscle and it doesn't do anything, there's not enough there. So the basic, you're okay with the nerve transfer, either end to side or end to end, as long as you have fibrillations and positive sharp waves on your electrodiagnostic studies. Those patients of mine that failed, not all of them had that. Then the next thing is, do you have enough motor end plates to get you up to the critical 30%, 20-30% that you need to have in order to have function? So every nerve, every axon will work 5 times as hard. So if you lose 10%, no problem. The others just work harder. But if you lose 80% of your axons, you're asking the 20%, every single one of them, to work 5 times as hard. That's a bit of an ask. If you only have 10%, then it's just not enough. So we don't know exactly when we see fibrillations and positive sharp waves, how many are there, but I think it's worthwhile doing it, especially such a easy operation as the SETS procedure. Or we can talk the same. I'm doing SETS now on the axillary nerve, posterior interosseous nerve, the musculocutaneous nerve, in a group of patients with radiculopathy. So here's the thing. In the papers from Egypt, you knew exactly when that nerve was cut. At the moment that was cut, completely cut, every single end plate was wanting a nerve. But when you have compression neuropathy, which is slowly progressive, you don't know when it started. And if you have radiculopathy, it's still progressive. So you need to be able to look at the electrodiagnostic study and know on the EMG when it's chronic and when there's still acute axons alive. I liken it to they're in a swimming pool and they're treading water and they want an axon or a rope to save them. But after a period of time, they'll drown, and you can put all the ropes in the pool, all the nerve transfers you want. There's not enough there to save. It's a long answer for.
Yeah. Thanks, Susan. We have a question from Abdulaziz Al-Hujairi. He asks about the status of ICG-like stains and imaging that's applicable for nerve tracking, and is there a way to do such tracking percutaneously and shows any discontinuity in nerve prior to exploration?
That is a huge topic and another topic. And that is a dream. That's what we want. I mentioned earlier, my husband's a thoracic surgeon, and he did the first double lung transplant research and the first double lung transplant. He's been president of everything, and he's editor of Annals of Thoracic Surgery. He is far more famous than I am. He has a talk on what advanced thoracic surgery in his career. And he says two things: research and imaging. And imagine we have had no imaging, essentially. So if we could have better imaging, if we could, when we know where the topography is, we know when we're doing a transfer, say median to radial nerve transfer, we know exactly what donors we're taking from the median nerve because we can stimulate it. But imagine when you have a denervated nerve, if you could know what part of it is, way of tracking, if you could do some retrograde tracking that wasn't ricine, that wasn't going to kill. So I don't have that's a fabulous, fabulous question, and I do not have a fabulous answer.
Did you trying MR neurography, and is MRI has a role in nerve surgery?
What I meant to say with Alex's response is, I think a new area is imaging, but not all institutions have the nerve MR. Hopkins does, I know that. Washington University doesn't. A smaller university in Columbia, Missouri does. So that is something that is, that's something that's not particularly available. The other thing we don't have as nerve surgeons is we don't have a partner in medicine. So imagine cardiac surgeons without cardiologists, pulmonary surgeons without pulmonologists. Imagine a nerve surgeon without a neurologist who was trained in traumatic nerve injuries. There are no such neurologists. When I started in pre-medicine, I was interested in nerve. When I was in medicine, I was going to be a neurologist. And I had my first baby in 4th year medicine. I started my internship. Lachlan was born June 18th, and I started my internship in July. I wanted a week off. I was in neurology program. I was in medicine, not surgery. And I asked a week off in August, and the dean of medicine said, no, maybe you shouldn't even be a doctor. If all you care about is your baby, it's ridiculous. Do something else. So I did something else. I went into surgery. But I had gone all through medical school knowing I was going to be a neurologist. And I am my own neurologist. And that is, there's two reasons why I've done what I've done. One is the research lab. Every single operation I do is based on my lab. I don't have any original ideas that I don't test in the lab. And that's one reason I seem so odd when I present at clinical meetings. People think, where did that come from? This woman must be nuts. And I didn't realize that. I should have said, well, this has been 20 years of studying this or 10 years of this. And having the research laboratory, which I inherited from Alan Hudson, who was chairman of neurosurgery at University of Toronto. But the other part of what I have is I know a lot about neurology and clinical examination. And if you ask our colleagues in medicine, the only specialty in internal medicine that really relies on the clinical examination is neurology. And so for me, having the videos to present without the clinical examination, it hurts me. It hurts me. And my sensory collapse test that I used to call scratch collapse test, I've worked on that for decades. It, for me, is a nerve MRI in my pocket. It's a phenomenal test, but I've only published one single paper on how to do it. Shame on me. One paper, PRS with Lorna Kahn as the lead article. So this is an infancy. This specialty, I was walking with my husband today outside before this talk, and that's my phone, and I had actually turned it off. It's on red, but it still came through. How dare it? But anyway, I was saying, you know, what I've done is good enough. And if I can't get the money to do that first part with the clinical judgment, if I can't do the physical exam, if I can't teach everybody everything I know, I've still done a good job. But I would like to do more of that first component, not just the surgeries, but also the thought process, the clinic. I like the clinic, the patient selection. I'll get this. Hello? Jill, hi. I'm talking to 300 surgeons from around the world right now. That's why I hung up on you. Sorry. Okay, bye. Bye-bye.
So we have 2 questions from Dr. Mackey. He asked about, is it possible to do nerve transfer for long-standing cases of sensory nerve injuries? And what about nerve implementation into muscles?
Okay, those are a bunch of questions. Let's have another one of these. Oh, this talk is just a fun talk. Yesterday, Andrew and I did an amazing talk that Andrew found some, not Zoom, but some better platform. And we just took the operation of median to radial nerve transfer, the 40-minute operation, and we just talked about it as it was playing. So I was talking about how I'm doing it, what I'm thinking while I'm doing that. Now, here's the thing about the first part of that question that was asked, sensory. So we taught one of the first questions was, how long can you do these transfers for motor, right? Because there's a time limit for motor.
Yeah.
Unfortunately, I think there's a time limit for sensory as well. And you know that if you look at someone with no sensation, they'll lose the pulp. Their fingers are tiny. They've lost the receptors. And it's not just the sensory receptors that are time dependent. It's not just the motor end plates that are time dependent, but the pathway along where they ride. So it's not just getting to the end plate, but this pathway becomes toxic. We have studied in the laboratory for the last 8 years, senescence of Schwann cells. Schwann cells become senescent, they're toxic, they stop regeneration. That's what we see in long nerve autografts, and that's what we see in nerve allografts, but at a shorter distance with the allografts than with the autografts. So the pathway, the short answer to that question is time matters with sensory, just like it does with motor. You can control nerve pain at any time by dwindling the regeneration, but to get the regeneration to actually give you good sensation, it's time dependent. And then the second question, what was the second one?
What about nerve implementation into muscles? Like inserting the nerve into muscle directly?
TMR. Okay, so if you direct neurotization into muscle, the ends of the nerve will try to find end plates, and they will make end plate connections, but they have to make a critical number to be functional. And that's why you'll see some people report they got function and most people report not. Because when you look at that curve, maybe you've seen a curve where we have a normal CMAP and then we lose the CMAP and you drop function. You have to get 20 to 30% of the end plates reinnervated to have function. So, but what you can do by taking a nerve, either sensory or motor, and just sticking it into deinnervated muscle, you will find that those nerves will reinnervate and it'll stop pain. That's the basis of TMR in part. Either take it into a deinnervated nerve close to the muscle or just stick it into the muscle, and it will give it something to do, and it will make the brain happier with respect to the neuroma component. It's so fun for me to see all your names here. Many of met many of you, and it's just joyful. Thank you.
So another question from my colleague Ahmed Ibrahim Salim at about at any level you cut off anterior interosseous nerve to do end to side?
Okay, this is a good, I'm not sure I'm getting this, but I want to answer like this. Can you see my hand here?
Yeah.
Yeah. So the pronator quadratus is here, and the nerve splits about midpoint. It splits into the different branches. That's where the motor end plates are. And so normally I would be going in about 9 centimeters proximal to the wrist crease because I want no tension. I've had patients where they've had an injury on the ulnar nerve here and they've done grafting and they have so-so intrinsics. I come here, I open up the carpal tunnel Guillaume's canal. I find the ulnar nerve here. I find the motor component here. Their repair or injuries here. Either I'll repair or graft it or someone else has repaired or grafted. I'll then come backwards on the pronator quadratus and I'll divide the pronator quadratus from distal to proximal. As soon as I get to the midpoint and pick up the AIN, then I'll take a graft and graft it end to side to the motor that way. It works great. So you're not obliged to just do this for issues that are proximal. So you can get it here, like proximal. You can have more distal. And if you take the AIN, distal, you have to have a graft to get it over, but at least you know you're taking 500 to 900 expendable motor fibers and you're directing it into exactly the recurrent branch of the motor nerve. So you know what you may get a great through your graft or repair here, but you're adding something distal. I don't know if that's exactly what you meant, but without drawing on something, that's what I took from that question.
So we have a question from Professor Magid al-Mufti. Professor Mufti is the ex-president of Egyptian Society of Plastic Surgery, and he was the ex-head of my department. Thank you, Prof. Mackinnon, for your enlightening presentation. Do you still abide by your rule of 18 in nerve repair?
18 months?
Yeah.
Yes, but at 11 months, if there's no fibrillations, it's too late. At 20 months, if there's fibrillations, it's not too late. So you need to have fibrillations motor unit potentials, and you need to have enough end plates fibrillating that you'll be able to get the critical 30% to get you back function. Otherwise, you'll get some back, but not enough to make a difference. And in those cases where there's still fibrillations and you're quite a while out, there's often some connection that's holding it, something protecting it. You see that with the cross facials and with facial, long time with the facial. There's a lot of those patients are going to have an etiology that's not complete transection. In general, complete transection by a year, it's not great. But we'll probably have some experiences now after COVID, because in the United States we don't even have access to electrodiagnostic studies now. So I found a neurologist who's in private practice, who's not in a big hospital where they're not treating COVID, and he said initially he would do studies for me the end of April, and then he said first week of May, and now he's saying May 12th he'll do a study for me. So we'll be having patients that are going to be potentially treated towards the end, because these questions you're asking are how long is too long?
Yeah.
With compression neuropathy, who knows how long is too long, because it's going on for a long time. If you ask the patient, say with severe cubital tunnel, they will tell you that I was doing fine, and then 3 months ago I lost function. And that's when they start to tip. So that means that they were doing fine. That means they had 30% of their nerve fibers working, and then they lost them. And so you then, even though they've had cubital tunnel for a long time, you have permission now to recover it. If the nerve's in continuity, if it's a neuritis, if it's compression, if it's radiculopathy, like Bell's palsy, it's in continuity. There's something holding those end plates longer. So you have more permission.
Thanks, Susan. There is a question from Masoud Muhammad. Do you do surgery for carpal tunnel syndrome on clinical finding or nerve study or both?
Well, I'm in the United States of America before COVID, who knows? But I always get electrodiagnostic studies. I mean, there's hardly a reason I would not get an electrodiagnostic study. And something like carpal tunnel, the reason, and cubital tunnel, well, for sure cubital tunnel, but carpal tunnel, I want to know, you don't need it for clinical exam or surgery, but if there's a problem, it is good to have a baseline. And because of this curve where this is no function, normal function, and this is normal nerves, no nerves. So because of the nervous system will maintain normal function until it's really bad, and then you'll lose function. Patients can be well along the progress with compression neuropathy where they've lost axons, but they're still doing fine. So you can see some people with SNAPs. We're looking at the sensory nerve action potentials now, and they'll have terrible sensory nerve action potential and decreased amplitude, but they got pretty good sensation. So if you operate on them, it's not going to take much to tip them over the edge. So I like to get the electrical studies. I can make my clinical exam, but I want to, the other thing with the electrical studies is in compression neuropathy, like carpal tunnel you're talking about, if their SNAP is very low, it's going to take a long time to get good function sensation back. If their electrical studies normal, they should be better the next day. So it helps to caution the patients as to how long it's going to take for them to get recovery. But you know, if I was in a situation, and all of us, I think, you would do a pretty, because it's the nerve issue is so much clinical examination. The problem is if you don't know how to do that clinical examination, if I can't figure out a way to get everything in my head out, then you're stuck with just relying on electrodiagnostic studies and imaging. But if you could use your brain to get into your patient's brain, to be able to do a really good neurological examination with all of the neurological testing that you do, then you don't need imaging and you don't need ultrasound. I don't need an ultrasound to tell me someone's got cubital tunnel, to tell me the nerve's enlarged. Or I laugh when our neurologists who are so brilliant now do ultrasounds so they can tell you it's carpal tunnel. Are you kidding me? Like, examine the patient and do the electrical study if you need to or want to stage it. But the MRI neurography, I think, is going to be exciting, but it's just not really available for us in the United States widely. This talk that I gave today was meant to be just sort of fun and not, no, you know, no, it's not meant to be the details on the surgical procedures. That's right. And so maybe you'd invite me back and we could just do one more boring education, not just sort of the overview of this this specialty of nerve surgery. So with this textbook that was published by TIMA in 2015, they said they want to do another run publishing it, and they want it updated. And it was such a lot of work. It took me 10 years to do that, 2015. And in the last year, we revised the whole thing. So it's really like a second edition because we revised it before we handed it to them. And I thought that we don't need it in 2020, but now that we started looking at it, there's so much new in the last 5 years that there's a lot that is still totally great and true in this textbook, but there's some nuances that are important. Like the topography at the elbow. In this textbook, I said there's no topography at the elbow. Well, there is topography at the elbow. It's FCU, FDP, sensory, intrinsics. The intrinsics are jammed against the bone of the cubital tunnel, and that's one of the reasons that they are more prone to tanking on us than or to being a problem than the FCU or FDP. So to talk today about the struggles of innovating a new specialty, I think is important so that every one of you knows how new it is and how important and what an important time for everyone to make contributions. Because no one knows much about anything as far as nerve surgery goes. It's brand new.
Thanks, Susan. Are you able to take some questions, some more questions?
If there are more that people, sure.
Yes, there is a question about a patient with CAT1 brachial plexus injury. Is there a specific nerve transfer, he say, with both median and ulnar intrinsic loss? Is there a specific nerve transfer or only 10 transfers available?
Yes. So for 81, first of all, 2007, 2007, yeah, October 2007, I did the first nerve transfers for C81, and that was the brachialis into the median. And then added to that, once we got that platform, so there was something, then we could add other things to it. Because all you have to work with is C7, but you have donors from C7, and you have even pronator quadratus. Sometimes we'll have component from C7. So, but the problem with pronator quadratus and ulnar intrinsics is that they're both C8T1, but there are some people with the pronator who will have pronator quadratus will have a C7. But otherwise, and then for the thenar, then tendon transfers. But otherwise, for ulnar intrinsics, in certainly C7, C8T1, there's nothing good for that I know of. We have tried the distal radial. Ida Fox wrote that up, but it's not very impressive. So no for the intrinsics unless you're lucky and have a component of the pronator quadratus still functioning.
And from Muhammad Sabahi, when you do proximal nerve transfer for later on free functional muscle transfer, is there any way to make sure that regeneration occurred within the nerve other than the tunnel sign?
So I didn't understand that. I didn't understand the levator.
No, like you do a nerve transfer as a first step before doing free functional muscle transfer for wrist.
Oh, yeah. No, Tunnel sign, I think is, well, Tunnel sign, if you knew the sensory collapse test, you could use that because it will tell you where the nerves are. So this last year in August in Science, ABDO, A-B-D-O from the Netherlands described a research study, and they described for the first time ever nociceptive Schwann cells around the free nerve endings. And in their experimental model, if they had any sensation, air, blowing, touch, scratch, any sensation, then the animals would have a response with withdrawal. So just as you use a Tunnel sign to follow a Tunnel sign, you can follow it with the sensory collapse test, but otherwise, no. Malasia has described the tender test. This is when the nerve is in continuity in order to tell you M1. I use that test a lot. Just pinch the biceps on the good side, a little uncomfortable. Pinch it on the side where you've innervated. Ooh, it hurts. It's tender. And that is M1, and that's when you get the first unmyelinated axons in there, and it hurts, and our therapists use that to start the motor re-education.
So Mina Faik asked, can we consider AIN to ulnar motor supercharge as a must procedure during any nerve repair? I think he means ulnar nerve. And is it
for me? Yes, for me.
So
yes,
it's
and
horse for ulnar nerve.
I'm not sure I know the question. Okay, so can we consider AIN to ulnar motor supercharge is a must procedure during any nerve repair, and the working horse among other nerve transfers most indicated. That's not a very good sentence. I don't know what that means. We did a survey a few years ago, Andrew and I did, to look to see if the nerve transfers were tipping. And if you look at radial nerve palsies, not so much on the median to radial because you can do tendon transfers. But if you look at intrinsic loss, the tendon transfers are not great. this transfer is so easy and it's very common. So I would say that it is the workhorse nerve transfer. It's the go-to nerve transfer. It's done the most. It has a very important contribution to deliver. It's basically in the ulnar motor, there's 1,200 motor axons, and in the AIN to the PQ, it varies between 5 and 900. I know that you guys in Egypt do a lot of this, and some of the AINs are really small. Most of them are pretty good. So, but at least you're bringing over extra motor axons that you don't need and that will add to try to get you up on that cliff to deliver function. But and I'm not saying anybody can do an AIN if you're a surgeon and a microsurgeon and know how to do good nerve surgery and know the topography. So you have to be able to see the topography, and there's that nice little line in between the motor and the sensory. It's almost as though when we were being designed, they knew in 2020, people will start looking and see these little microvessels. And those microvessels are the lead. They tell us, they mark, they help us know motor from sensory topography. So yes, I agree with all of that, all of your question there. Yes, it's a great operation. Yes, it's the most commonest. Yes, I would do it. But I wouldn't do that if there were no fibrillations, because it won't work. And I wouldn't do it if they had, say, a conduction block at the elbow on the ulnar nerve, and they just can't get at those axons. And so when you remember that little drawing I had on the table in the operating room with all these little stickers and the arrows, there's mostly no, 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 no. And if all of this happens, then it's yes. So you have to have lost enough axons. Otherwise, you just correct the conduction block at the elbow, and then it myelinates, and your axons are already there. So you have to be able to read the ADX to understand that. And I understand, Guda, you gave a talk just recently on how to read the ADX. It took me years to learn how to read that ADX. And I learned how to do it because my EMG neurologists are right next to my clinic, and I would go over there and bother them all the time. And they would only let me ask a few questions a day, and then they would tell me to go away. And so it took me a long time to get their information. But the information that Guda was talking at his talk just recently, and the information that we have in the JBJS article from last year with Holly Power as the lead author, that information is known by the neurologist. They just think we're not particularly smart enough to be able to interpret it and the ADX, and so they tell us, well, telling us it's severe ulnar neuropathy, we already know it's a severe ulnar neuropathy. So we need to know the details of that. The other thing is a lot of the information comes from the EMG, and that's very qualitative, and that is something that you have to have a good neurologist and skilled in that. But the CMAPs and the CMAPs, SNAPs aren't reliable, but CMAPs are very reliable to tell you whether or not you need to add something.
So last question is about, have you been involved in any stem cell treatment for recent neural injuries?
I put an NIH grant in on stem cells and they laughed me out of the room. And so I went to the neurologist, not the neurologist, the basic scientist at WashU that studies stem cells. And I said, you know, they didn't like this aim at all. And experts in stem cells at Washington University, which is one of the 5th top ranked schools in the country, do not think that stem cells right now are helpful in neurological problems. And the National Institute of Health will not fund that right now. So no. Could it be? Well, I thought it was a good idea, but the National Institute of Health didn't think it was a good idea. Not now. They have money. They spend the money where they think they have the best investment. It was in that grant that they funded the Schwann cell senescence. They liked that. And that was piggybacking off of cellular senescence in general. So they funded that. And that actually led us down a very good pathway. But that is just my opinion. Others are definitely obviously studying that, but it hasn't, it's a long way. It's a good idea, but way long way to tip.
Thanks, Susan.
Thank you all so much.
Time. We get 200 attendance for your lecture today. And we hope that you can give us more and more.
Yes, you can invite Andrew and I back. Right now we're busy putting a couple of grants in though, but as soon as we get that done, invite us back, right, Andrew?
Andrew, I think he is waiting and ready to go out.
Okay.
Oh, no. Yep. I'm great.
I don't think we could do the streaming of the surgeries though. Do you, Andrew? So.
We could. It's just going to take a little bit more technical stuff that I have to figure out first. So.
Yeah, great. Well, it's wonderful to see you all again, and I recognize so many faces and names, and I thought it was terrific. Andrew, what'd you think? Great?
Oh, yeah, that went well.
Great. Okay. Thank you so much.
Thanks, Susan. Thanks, Andrew. Thank you very much.
Stay safe. Stay healthy.
Yeah,
See you again.
You too. Thank you.
Thank
Bye-bye.
you.
Thanks a lot.
Bye.